Good afternoon, everybody. It's a pleasure to be here again in DAR 2023 amongst this highly prestigious and elegant faculty of speakers and delegates. And it's always a pleasure to be as part of the DAR conferences every year. I've been asked to cover the updates on the SGLT2 inhibitors safety in Ramadan. What did we get in the last couple of years? And please allow me to go straight away into the topic that it goes without saying that having diabetes and trying to fast Ramadan may come with some complications. That includes hypovolemia, hypoglycemia, ketonemia, a probable decline in renal function, and this is expected to be quite reversible, and on and off hyperglycemia. So what happens if we combine this scenario with a prescription of SGLT2 inhibitors? And we all know that SGLT2 inhibitors are considered as one of the osmotic diuresis agents. So having a SGLT2 inhibitors on board may increase the risk of hypovolemia more and more, may increase the risk of hypoglycemia being a glucose lowering agent, may carry some minor risk of euglycemic ketoacidosis, and it adds more spices on the decline of renal function. So this is what we expect if we combine these two scenarios together. That theoretically we'll have more hypovolemia, more hypoglycemia, more risk of ketonemia, decline in renal function, and the hyperglycemia might be equalized by the glucose lowering agent addition to the diabetes background. So what we got until 2019 is just a handful of safety studies that assessed different types of SGLT2 inhibitors, dapagliflozin, canagliflozin, and only one study in 2019 that we did, it assessed a combination of included all the available SGLT2 inhibitors at that time in our facility, dapagliflozin, canagliflozin, and empagliflozin. That's more or less considered as history now, but please allow me just to have a quick glimpse on what we got from 2016 to 2019. Different studies from different parts of the world, basically Malaysia, Singapore, and 3 studies from the United Arab Emirates, Dubai Health Authority. And all the studies have assessed the HbA1c changes before and after Ramadan, eGFR changes before and after, the risk of dehydration, risk of hypoglycemia, occurrence of DKA thromboembolic phenomena, and hospitalization. So SGLT2 inhibitors was quite a safe agent to introduce during Ramadan out of all those studies, and the risk of hypoglycemia was significant towards in favor of SGLT2 inhibitors. In the one study from Malaysia, it was significantly again in favor of SGLT2 inhibitors in Kratos study, canagliflozin by Hassanin and his team. And it was not significantly different between SGLT2 and non-SGLT2 background therapy in the rest of the studies until that time. And the HbA1c changes was also in favor of SGLT2 inhibitor in 2 of those studies. And only one study have shown risk of dehydration and a negative fluid homeostasis. That was Kratos study, and it was significantly in favor of non-SGLT2 inhibitors group. So that was until 2019. So what did we get afterwards, apart from the COVID-19? This is an interesting study conducted in Pakistan. They assessed the SGLT2 inhibitors, both empagliflozin and dapagliflozin, and it was a prospective observational study. They included around 82 patients aged between 21 to 70 years of age. And if a patient discontinued the SGLT2 inhibitors or did fast less than 15 days, then he would be excluded from the trial. The total trial duration was 3 months, 4 weeks before Ramadan, and then Ramadan, and then 6 weeks after Ramadan. And the pre-Ramadan visit was basically to give the educational tips and to do the biomedical and biometric assessment. During Ramadan, it was a telephonic consultation, basically to look into the complications of fasting and SGLT2 administration. And the following 6 weeks after Ramadan was a combination of questionnaire and again, biometric and biochemical assessment of those patients. Similar to most of the preceding studies, there was no major difference in HbA1c, no major difference in weight, no major difference in creatinine level, systolic blood pressure, and diastolic blood pressure. However, there was a statistically significant drop in eGFR from 94 in mean to 87. And that was also being reported in multiple studies in the previous years. And this decline in eGFR is absolutely reversible in a couple of weeks to months following the month of Ramadan. So it should not be a worrying finding afterwards. So the hypoglycemia did occur in those patients in 7.3% only, and the timing of hypoglycemia was a bit tricky. So where the only 20% of patients did have a hypoglycemia during morning time, 56% of patients did have the hypoglycemia during the midday, and only 12% did have the hypoglycemia just before iftar. And that was not easily explainable. Only what we can say is that group of people was at age of productivity. Probably they were working during the fasting hours, midday, more towards labor-based jobs. So probably the hypoglycemia did occur during the midday more than the morning and the other end of the day of the fasting time. So that was the only explanation that could explain the occurrence of hypoglycemia in midday. The patients who did fast Ramadan 15 to 25 days were at least 7.3%, while majority of the patients, 92% of patients in this study did fast Ramadan at least more than 25 days out of 30. So the tolerability of SGLT2 in this population was quite high, and the majority of patients did manage to fast the month of Ramadan. Hospitalization due to hypo or hyperglycemia was not significant, while the reported dehydration was a little bit higher in the SGLT2 patients in this study. A second study was basically focusing on empagliflozin. It was from Egypt, and it's called the EMPA Ramadan. They included 300 patients. They randomized them into two groups, almost equal number, 157 and 143, on a background of metformin 2000 milligrams. Group A, the people who received the SGLT2 inhibitors, and Group B, those who received DPP4 inhibitors, and the dose was stabilized at least a month before Ramadan. 3 visits, 1 visit before Ramadan, and the second visit was within 2 weeks after Ramadan, and another visit at least 1 month after Ramadan, another 3-month duration of study. So this study is interesting. They evaluated the complications of the combination of these glucose-lowering agents and fasting, comparing the SGLT2 inhibitors and DPP4 inhibitors. The gray bar is represents the SGLT2 inhibitors, and the red one represents the DPP4. So the occurrence of UTI across the study duration was 1.9 in SGLT2 group compared to 3.5% in DPP4 inhibitors. And this is not, again, not easily explainable, but the authors did explain that it could be just a bias from the group of DPP4 inhibitors and could be the personal hygiene or other influences. It's not basically related to the medications given, glucose-lowering agents given. The risk of hypoglycemia was higher in DPP4 inhibitors compared to SGLT2 inhibitors, almost comparable genital infections, a little bit higher GI upset and in DPP4 inhibitors, and a little bit higher risk of skin rash compared to in SGLT2 compared to DPP4 inhibitors. So comparing the UTI occurrence between the total study duration and during the month of Ramadan, during the fasting time, the UTI occurrence dropped from the para-Ramadan period compared to during Ramadan period from 1.9 total study duration to 0.6 in SGLT2 inhibitors, and from 3.5% to 0.7. So against the expectations in some theories, the risk of UTI in Ramadan is less than the out of Ramadan time. So, and there was no serious adverse events reported during this study. My last study is what we call the DAR Global Survey. And this is the huge survey conducted across 20 countries, and more than 5,800 patients did participate in this mega survey. 2,379 of them were on SGLT2 inhibitors, combination either of empagliflozin or dapagliflozin. And EMPA represent around 68% compared to 31% dapagliflozin. And across the coming slides, the flow of the graphs will be in the following manner. The first group will be the SGLT2 on background on metformin or other glucose-lowering agents apart from sulfonylurea and insulin. The second group will be the SGLT2 plus sulfonylurea but no insulin. The third group will be the SGLT2 inhibitors with insulin, whether basal or MDI, but excluding the sulfonylurea. And the last group will be the combination of all, the SGLT2 inhibitors, sulfonylurea, and insulin. Those are the number represented in this study. Almost 1,000 patients in SGLT2 plus insulin, excluding sulfonylurea, around 700 in plain SGLT2 inhibitors, no sulfonylurea or insulin, and a smaller group in SGLT2 plus sulfonylurea, and the least number was the combination of all. What we got from this study that women are being prescribed SGLT2 inhibitors more than men, and the red bars represents males, and the gray bar represents the males. So the opposite males are being prescribed with SGLT2 inhibitors more than females, actually. The age, the mean age is as expected. As the disease progresses, as the age progresses, the demand for further SGLT glucose lowering agents inclusion is higher. So the more combination, the more mean of age, starting from 50 years of age in plain sulfonylurea on a background of metformin or other glucose lowering agents, going to a mean of 56 years in the combination of different glucose lowering agents. And that's pretty explainable, unexpected. Obesity rate was more in the SGLT2 plus insulin group. Almost fifth of the group did have obesity, compared to 187 only in the SGLT2 plus metformin or other glucose lowering agents. So this might not add much, but Probably the insulin component might have added a little bit on obesity, but that was not represented in the combination of all in the last group. Duration of diabetes is also explainable that the people who used to be on insulin had at least one-fold extra of duration of diabetes, almost double. People on on SGLT2 inhibitors alone, no SUs, no insulin, had almost half of the duration of diabetes compared to people on insulin, either basal or MDI. So, and that's again explainable and goes without saying. This is the segregation of duration of diabetes that the majority of people on simple oral hypoglycemic agents, their duration of diabetes was less than 10%. The gray bar in the first group, almost 71% of those population did have diabetes for less than 10 years, compared to only 20% of those of population on SGLT2 inhibitors, sulfonylurea, and insulin. Only 20% did have a duration of diabetes less than 10 years, and half of them did have a duration of diabetes of 10 to 20 years. So those people are more high-risk population given the duration of diabetes and multiple medications, the polypharmacy. The mean HbA1c also pretty much explaining the diversity of the study population. So the people on oral hypoglycemic agents had much better HbA1c compared to those on oral hypoglycemic agents plus insulin, from 7.8% mean HbA1c to 9.1% mean HbA1c in SGLT2 plus sulfonylurea, plus insulin, sorry, excluding sulfonylurea, and 8.8% in people with combination of all. Majority of the population, study population, did intend to fast, from 91% to 82%, going down to combo group or the polypharmacy group. But no intention to fast also increased from people who were on oral hypoglycemic agents from 8.4%, the red bars, going up to 20% in when the people used to have insulin with a basal or MDI. So the having insulinization or having insulin on a background therapy increases the intention to the non-intention to fast and probability of breaking the fast. So that's again, it's an important tip that we might need to tackle in our clinical guidelines and the seasonal education pre-Ramadan and afterwards. The complications percentage, the hypoglycemia was the least in the oral hypoglycemic agents, whether the SGLT2 inhibitors alone or SGLT2 inhibitors with sulfonylurea, 8% in the dark gray bar to 9.6% in the second group, and it jumps almost twice as much as the oral hypoglycemic agents, 16% in when the insulin is added to SGLT2 inhibitors, and 20% when the combination of SGLT2, sulfonylurea, and insulin. So the risk of hypoglycemia increases when the multiple medications are on board, especially when the insulin is introduced. The ER visits was minimal in SGLT2 group, was zero in the sulfonylurea plus the SGLT2 inhibitors, and it goes more and more when we introduce the insulin and when we combine the insulin and sulfonylurea, from 3.4 to 6.9% of total population. The hyperglycemia also increases as the disease complicates more and more. Given the data that we presented today and the data that we got in the previous years, the International Diabetes Federation and their clinical international guidelines have concluded that the SGLT2 inhibitors should be initiated 2 to 4 weeks prior to Ramadan. If we decided to initiate within these 2 weeks, then we start with a lower dose and then we build it up. Increasing fluid intake during the non-fasting hours of Ramadan is recommended, and there is no dose adjustment is required during Ramadan days. So with that, dear colleagues and friends, please allow me to conclude that the SGLT2 in Ramadan so far are well tolerated during Ramadan by majority of type 2 diabetes patients. The use of SGLT2 inhibitors carries a negligible hypoglycemia risk. Given the current data, the confidence in safety of SGLT2 inhibitors is more or less satisfactory. Risk stratification, hydration, patient empowerment are essential. We may need to adjust the adjunct insulin plus or minus sulfonylurea before the fasting days, and if already on SGLT2 inhibitors, please keep him or her on the same dose during the month of Ramadan. And with that, I'd like to thank you very much for your kind attention, and we'll be happy to have any questions in the Q&A session. Thank you.